came back, he did fellowship in oncology. Now from the ETSU, he's been with us for the last 5 years, and he's also the fellowship program director. So he's going to talk about peripheral blood smear. So we can start now.
Okay. Good afternoon, and thank you for being patient. The 12 o'clock slot is always a tough one to fill, and I know how tired you all are after a long morning's session. So without further ado, I'll get started. My topic today, and this is the one that I picked, and I picked for a reason, is the peripheral smear, a window into the human body and hematology. There's a reason why I picked this topic. From our division over the last 5 or 6 years, we've brought forward over a dozen grand rounds in the last 6 years, and I've personally done about 6 of them. Some of them are very specific, and we talk about CML and molecular targeting in CML, or targeted therapies on non-small cell lung cancer as such. And some of them were broad-based, and I talked about cancer and thrombosis. We talked about cancer screening in general. And as we move to an era where we have a dizzying array of tests and molecular tests and specialized testing, it seems like we seem to move away from some of the basics, and that was one reason why I thought I'll pick up the peripheral smear and talk about it. I listened to the last little bit in your conversation in the last session for the last 5 minutes, and I hear the angst, and I think there were points well made talking about the basics. My mantra when I talk to med students is always the answer is at the bedside. All answers are at the bedside. The patient is king, listen to him. And there are things that you want to do at the bedside and then connect the dots. And if the dots don't connect, go back and look at things again. So when I talk to my hemonc fellows, I say, especially when we do cancer surveillance, you don't know when this cancer is recurring. You don't know when a back pain or a headache is significant and when it's not. And it's a three-legged stool as far as we're concerned in oncology. You've got the patient and the clinical characteristics, you've got the biochemical characteristics and labs, and you've got the radiographic picture. We never rely on any one thing. We want every little piece of that puzzle to kind of fit in well. So along those lines, here is the peripheral smear. It's something that an internist needs to know. You don't need to be an ace at this. I wasn't. I worked as an internist for 10 years, so a lot of what I'm doing is pretty much hands-on. But these are skills that you want to pick up. And this gives you a wonderful insight into the human body. You're way ahead of your RT-PCR. You're way ahead of your FISH testing if you're able to take a little sneak peek into the peripheral smear and see what's going on. You've got that patient in the ICU. You've got the patient in the clinic. You've got platelet counts of 1.1 million. Is that something really serious? Is it not? It helps to know what the peripheral smear tells you. So I have no disclosures to make. The objectives of the talk today are, 1, to study the CBC and its components, evaluate the normal and the abnormal peripheral smear. We're going to do some case-based discussions. We'll have some hematology scenarios to throw at you just to make it a little more exciting so that it's not just a didactic session. We will discuss cytopenias, including anemia, and we'll discuss some cytoses. When we talk about blood counts, we've got low counts, and then we've got high counts, and then we've got some abnormalities, and so we'll look at both cytopenias and cytoses. Towards the end of the session, I've got about 8 or 10 slides which are interesting. They are curiosities, they are oddities, that actually tell you about systemic illness that could be reflected in the peripheral smear. We do have some questions to ask of the audience, and we'll have the audience response system. So make this interactive. Feel free to guess. It's okay to be wrong. There are no negative marking for being wrong out here, but I really want you, this is your session, so I really want you guys to kind of dig in and see what we've got here. So question number 1. Take a good look at the peripheral smear. What do you think we have there? Hypersegmented neutrophils, pseudocytes, thrombocytopenia, or others. We'll give you all about 20-30 seconds, and then we'll go to the polling. We've got lots of questions, so we'll have you guys be as brisk as you can. Okay. Okay, we had it's a good, nice little spread there. And I cheated. This was not fair. I shouldn't have thrown an other there, but the answer actually is other. And what I wanted to start with was basically, if I put down saying a normal peripheral smear, I knew most of you would have gone for it. And I wanted you all to recognize that this is pretty much what a garden variety normal peripheral smear would look like. Those are normal neutrophils. There's little itty-bitty dots there. Those are platelets. We really don't have any lymphocytes or monocytes on this. These are red blood cells. They're fairly uniform, normocytic, normochromic. A third of the red blood cell has central pallor. Nice, normochromic, normocytic red blood cells and a normal peripheral smear. You have to know the normal to know the abnormal. So when I was a resident right here 20 years ago, I had attendings who said, go ahead, I know you guys have restrictions nowadays as we get cost effective. Go ahead and order as many ACE tests, ACE levels as you want. Go ahead and order as many CRPs as you can get. You have to order enough of them to know the normals, to know the ones that were falsely normal and falsely abnormal, to really get a sense of where you have a true abnormality. So that's the question number one. So we're talking about the peripheral smear, and 3 cell lines is what we're going to repeatedly discuss: red blood cells, white blood cells, and platelets, and that's a normal peripheral smear to start with. So this is what's something that all of you order every day, probably the most common test that an internist or a physician would order, and that's the CBC. I'm not going to go over all these basics. You've got the white blood cells, you know what the normals are, hemoglobin, platelet. To us, when I see a hemonc fellow put down a CBC, I really want him to tell me what the MCV is every time he's got the hemoglobin out there. And we certainly take a look at the differential. There are CBC machines out there that will do only a CBC without a diff when you go out and practice, and that's fine from a general internist and a primary care perspective. As a hematologist, we really want the differential because a lot of the action is here in the differential for us. So what we're going to talk about is cytopenias, red blood cell line, anemia, thrombocytopenia, leukopenia, and cytoses, which is polycythemia, thrombocytosis, and leukocytosis. A lot of interest for us between neutrophilia and eosinophilia, between monocytosis and lymphocytosis, and we'll try and tease this out again. So case number 1. Ms. Cooper, a 24-year-old female grad student, comes into the campus clinic complaining of fatigue for a year or two. She has been under a lot of stress and feels emotionally run down. She denies chest pain, abdominal pain, alteration of bowel habits, or blood per rectum. She has now dropped out of Zumba lessons due to shortness of breath. She has no other medical issues and is up to date with her pap smears and GYN exams. She has struggled with heavy menstrual periods since menarche at age 12. She does not smoke but consumes alcohol on a social basis. She admits to food cravings, especially consuming ice directly from the kitchen freezer. These are all real life scenarios. I've created these questions, actually having patients in mind, patients we've seen in the clinic. And every little bit of history or lack of history or a positive or a negative history or exam has been carefully thought out to try and help you guys out there. These questions are not meant to be teasers. They're just meant to kind of be a framework to have further discussion. So that's the case history. At the end of the history, we always say, make a diagnosis. Like someone said, you make a diagnosis at the end of history, you confirm it at the end of the physical exam, and then you double confirm it with the icing on the cake, which is radiography, molecular tests, labs, etc. So any thoughts about what this patient might have? Good deal. So there's your question, basically, even before you get to the peripheral smear. What do you see there? I'm not going to throw out something as easy as iron deficiency, so I'm going to ask you to actually look at that smear and tell me, what are you seeing? Microcytic anemia only? Rouleau formation, dimorphic picture, the S should not be there, sickle cell anemia. Okay, take a look at it. Just like the ABIM, you think you've got the answer and they tell you at the end of the question, and I feel so cheated. I'm like, oh my, whoa, I wonder what they have after this. So basically I'm asking you to describe the snapshot of what you see in front of you. Go ahead and take a crack at it, and I'll do the polling. Wonderful. So dimorphic picture is what I'm trying to pull out and show you here. Yes, the patient has iron deficiency. The pica and the food craving gave the story away, but the rest of the history was fairly classic. And we're looking for microcytic hypochromic anemia, but that's not all that's there in this peripheral smear picture. You see microcytic anemia. You see some red cells that are really small, significant central pallor, but then you see some other cells which are perfectly normal. This is a patient who has been transfused and therefore has a dimorphic picture in the blood. When you look at the peripheral smear, you see absolutely normal red blood cells, but you also see microcytic anemia, along with a couple of other things that we'll talk about in in a follow-up slide. So dimorphic picture is the right answer. And this would have been the rest of the exam, and we won't spend too much time, but she was pale, fidgety, nervous, tachycardia, a bounding pulse, hemocult negative, understandably, because we know where her blood loss is coming from. It's 1+ spitting edema, and we've said there's no hepatosplenomegaly, so you don't have to think about hemoglobinopathies and things like that. So that was her physical exam. This is what her CBC came out as. 8.6 on the hemoglobin, hematocrit is 26.4. Remember, it's a 1:3 ratio. The MCV came back pretty low, as expected, 68.2. Tells you that this was chronic. Acute blood loss does not cause microcytosis right away. It's chronic anemia, chronic iron loss that causes microcytic anemia. And she gave you that history, 1 or 2 years of slowly worsening fatigue. The differential looks good. And so here's another picture of what microcytic hypochromic anemia would look like. Look at these cells. Significant central pallor, far smaller than the other cells. And so that's your microcytic anemia. If you go back to the smear that we saw, we have a couple of other things that are worth looking at. Cigar-shaped cells. That's a cigar-shaped cell. That's a cigar-shaped cell. That's a cigar-shaped cell. That's a cigar-shaped cell. And we've got some target cells. There's a target cell out there there's another target cell overlapping on another cell. And you might see target cells in liver disease. You might see target cells in microcytic anemia. So this is fairly classic. It's not too often that you see cigar-shaped cells, but when you do see those, they give you an idea that yes, this is certainly microcytic anemia. Begins to fit. You had the history, you had the blood count, you have the MCV. Now you get the iron levels and take a look at it. And sure enough, iron is 22, TIBC is 405. As you all know, iron saturation is iron divided by TIBC into 100. The ferritin is 6. The soluble transferrin receptor assay is high, which is what you would expect. The B12, the folate, the haptoglobin, all those are within normal limits. That's a snapshot to tell you what the normals are. And the retic count is 1.3. So she's not compensating because she just doesn't have enough iron to compensate and get her retics up. So anemia by definition is a decrease in red blood cell mass. It could be symptomatic, it could be asymptomatic, it could be acute or chronic. And we certainly divide anemia based on the MCV into normocytic, microcytic, or macrocytic. Ever since we did pathology and Robbins, we've talked about microcytic anemia, macrocytic anemia, and that is a very valuable tool to segregate anemia with. One of the important things I would push you all to think about is the reticulocyte count. We have things which are the absolute reticulocyte count and the corrected reticulocyte count. Don't worry about the details. The lab spits it out for you. It'll calculate the corrected retic count for you. What you do want to remember is that if the retic count is not up for a certain degree of anemia, then you've got a marrow that's not working too well. And that's important for us to know because when we have a retic that's up, I know the marrow is good. So as a hematologist, when I come on board, I'm delighted when the retic is up or when it's at least compensating, then I know I don't have to worry about MDS and other states. So if the retic is not up in compensation, we think about hypoproliferative anemia, which would be things like MDS, aplastic anemia, iron deficiency anemia. If the retic is up, as you all know, we worry about hemolytic anemia and blood loss. So that's straight from West Market Street. That's from Krispy Kreme, right? Now, that's your typical biconcave discoid red blood cell under a scanning electron microscope. And that's just absolutely glorious how nature or evolution has created the cell to perfectly navigate the circulation. So some of the most path-breaking developments in our understanding of human genetics actually came from hematology and actually came from understanding the red blood cell morphology and why the morphology was different in different populations. Microcytic anemia, you all know this stuff pretty well. Iron deficiency, the differential is thalassemia. Remember, anemia of chronic disease could be microcytic. Lead poisoning, sideroblastic anemia, copper deficiency, and zinc poisoning will close it out. Some iron metabolism factoids, the red blood cell lifespan is 120 days, 1% cell turnover, which actually calculates out to be 20 ml of blood loss internally every day, which is about 20 milligrams of iron. You should be able to reuse that iron. These are some daily iron requirements in men, in women, and bioavailability is based on that. The etiology of iron deficiency, fairly simple. There could be increased demand, and we all know this, infancy, pregnancy. Don't forget ESA use, erythropoietin use. Increased blood loss, we've talked about that. Don't forget people going for regular blood donation. And then decreased iron intake or absorption. And I should put down the malabsorption today will include patients who have gastric bypass surgery. Patients come to see me with gastric bypass surgery with anemia due to two reasons. They have a B12 deficiency and an iron deficiency, which is purely due to malabsorption. So case number 2, 52-year-old male is admitted from the emergency room after a CBC revealed a hemoglobin of 5.6 with a hematocrit of 17.1. He reports fatigue, exertional shortness of breath, and dizziness in the last 5 to 6 days. He denies chest pain or abdominal pain, but mentions dark-colored urine in the last few days. Exam reveals a pale 52-year-old male in no distress. He looks tired and ill. Pallor and icterus of the mucous membranes are noted. Heart rate is 128. Blood pressure is 94/58. Respiratory rate is 16. Cardiorespiratory evaluation is unremarkable except for tachycardia. Abdomen reveals no organomegaly. Extremities reveal toothless edema. After a type and cross match, 2 units of red blood cells are transfused with pre-meds. A repeat CBC 4 hours later reveals that the hemoglobin barely went up. We started at 5.6, we're now 6.2. And the patient's heart rate is, however, 140. He has worsening dyspnea. And the nurse calls you mentioning the patient is getting restless, refusing to lie down in bed. What next? So, man with significant anemia has been transfused and he's getting restless and he's not getting any better with your transfusion. That's the synopsis of what we have there. And that's what his CBC looks like. A hemoglobin of 5.6, MCV is 103. RDW, we'll pay some attention to that number, it's 22. The platelets and the white cells are normal, so we have a single cell line issue with significant anemia, very symptomatic, and the differential is normal. Then we give you some more labs, and this might give the story away. We've got some bilirubin that's elevated, a direct that's only marginally elevated, and there's your retic, there's your LDH, there's your haptoglobin. And so everything's stacking up towards a story of lovely hemolytic anemia, and we've thrown in a direct Coombs that's positive. That's the peripheral smear on this patient, and basically what I'd love to bring to your attention is with a Coombs positive hemolytic anemia, this patient could potentially have autoimmune hemolytic anemia. And on the CBC, you may not see a whole lot of stuff other than this stuff. That's polychromasia, that's a reticulocyte count, reticulocyte count, reticulocyte count. Those cells are a little larger and they have a slightly different color. And if you actually play with your microscope and you change your fine tuning on it, you'll actually see the violet color change back and forth, which your normal red blood cell will not do. And that tells you an idea, hey, that's a retic. And basically that's all you're seeing in this peripheral smear. In autoimmune hemolysis, you won't see a whole lot of other stuff. You may see an odd spherocyte. In this case, this is a red blood cell. That's not a myeloid cell. These are myeloid cells. This is a red blood cell, and it's a nucleated red blood cell, and it's actually got a binucleate red blood cell out there. And so autoimmune hemolytic anemia may not have a whole lot of stuff on the CBC, on the peripheral smear, other than the fact that you may see reticulocytosis. And I was showing this peripheral smear just to show you how you ought to be able to recognize reticulocytosis. And that brings us to hemolytic anemia. You have intracorpuscular defects, extracorpuscular defects. You have inherited defects, acquired hemolytic anemias. Intravascular hemolysis might happen, extravascular hemolysis might be the issue. But for us in hematology, a wonderful way to segregate hemolytic anemias is based on the Coombs test and to say, is this Coombs positive or is it Coombs negative? Those of you who rotate with us in hematology, you'll hear this at least once being discussed on the inpatient rounds about Coombs positive and Coombs negative hemolysis, because the differential diagnosis is beautifully narrowed down for you. These are what the defects might look like. Since we're talking about peripheral smears, you need to know what these smears might be. This is hereditary spherocytosis. Perfectly spherical spherocytes, no central pallor, and that's classic for hereditary spherocytosis. This is, as you all can see, sickle cell anemia, fairly classic. We've seen these on and off in pictures in our internal medicine textbooks, and we've seen that in our pathology textbooks, but it's worthwhile to look at it under the microscope one time. The first blast and the first band and the first schistocyte that you see under the microscope is imprinted in your mind. You own it, unlike a picture in a textbook. From there on, in the middle of the night, wherever you're working, if you happen to just take a peek, you might know it. You're not expected to know it. You're not asked to know it. But it's lovely to say, I have a snapshot. I actually have a window into that bloodstream and I know what's going on. Nothing gives me more comfort on a Sunday afternoon when I'm finishing my weekly inpatient rounds than doing smear rounds with my fellows, because we sit down and look at all the smears that we saw over the week from the ICU, from the floors, etc. And no matter how positive or negative the hit test and the optical density might be, it is important for me to be able to see those thrombocytes and to see what's going on in the circulation. The level of comfort that you get from that is incredible. The same way that you get from other testing that you see in your patients, and from actually seeing the patient right at the bedside. So here we are, intracorpuscular defects on a peripheral smear. Here are some other defects that you might see. This is classic. This is G6PD deficiency. The defect is intracorpuscular. And what happens in G6PD is that you have oxidation of the hemoglobin. When you have oxidation of the hemoglobin, you form these Haynes bodies. You cannot see this smear under a peripheral, in the peripheral blood smear. You need supravital stains to be able to see this. Well, this is a picture of a supravital stain that shows you this is what the oxidated hemoglobin would look like. The sulfhydryl portion is oxidated. Once you have oxidation, there is crystallization of the hemoglobin, and therefore that cell membrane right next to that crystallized hemoglobin gets defective. And when that happens, and when that red blood cell, remember that Krispy Kreme red blood cell floating through the circulation in the spleen says, hey, there's something wrong with this cell membrane, I'm going to take a bite out of it. And that's what happens. You get bite cells. These are called degmocytes. These are the bite cells that were discovered in G6PD deficiency when someone has a crisis. And that's how they came up with some of the genetics in hematology on G6PD, was basically looking at this peripheral smear. They really did not have this part. They had this part, and they figured out G6PD deficiency. You could have extracorpuscular defects where the deficiency is not within the red blood cell, but external. So this could be someone with a prosthetic heart valve and who's having hemolysis. And so this is microangiopathic hemolysis that causes helmet cells or schistocytes. And once you've looked at them under the microscope, you won't forget them. That is a schistocyte. That is a schistocyte. That is a schistocyte. They are never cleanly cut. They seem like they've been sheared off. And when they seem like they've been sheared off, it'll leave you little edges to it. It looks like it's a helmet with two sides of the strap, or maybe one side of the strap of the helmet hanging on. And so that would be your helmet cell. And that's a schistocyte. And that tells you that there is destruction of the red blood cell intravascularly in a shearing mechanism. This is something that you see very classically when you have cold agglutinin disease. You just have RBC agglutination. And that just narrows it down. The minute you take one look at it under the microscope, you say this is cold agglutinin disease, this is RBC agglutination. So hemolytic anemia, coming back to what we were talking about, can be Coombs positive, Coombs negative, and that's it. Hemolysis seems like a very complicated story, but it's a very simple differential. If you're Coombs positive, it could be neonatal jaundice, neonatal anemia. It could be a mismatched RBC transfusion. Autoimmune hemolytic anemia is your classic Coombs positive hemolytic anemia, and you can have drug-induced hemolysis. If you have Coombs negative, the one big thing you need to remember is TTP. TTP causes Coombs negative hemolysis. And if you have TTP, the patient is very sick. He's in the ICU, he's crashing, he's on the ventilator, renal dysfunction, he could have mental status changes. We know the pentad of TTP, right? What's the closest differential to TTP? DIC. And that's right there. And you can see schistocytes in DIC. You won't see as many. So what is the definition of how many should you see before you say there is a schistocyte in the peripheral smear? Because every once in a while you may see a schistocyte here and there in someone with an artificial heart valve who's not having a whole lot of hemolysis. So you need 2 per high power field. Now if you look at 40 fields and you find 1 or 2 fields with 2 of them in each field, that's still not good enough. In TTP, you'll see field after field. Maybe there may be a couple of fields that you won't see a schistocyte, but out of 40 fields that you look at, 35 of them will have a schistocyte. 30 out of those 35 will easily have 2 in them, 3 in them. That's what schistocyte. That's what you see in TTP. In DIC, you could see the same schistocytes, but not as many, but a lot more than what you would normally see in, say, in prosthetic heart valve hemolysis. So the closest differential for a Coombs negative hemolysis is TTP, DIC, or you throw in chronic liver disease out there. Drug-induced hemolysis could go both ways. There are some drugs that cause Coombs positive, some cause Coombs negative. So that leaves you with just 3 others, and I call them the 3 pathies that show up in your Coombs negative hemolysis. There's membranopathy, which is from spherocytosis and elliptocytosis. It could be hemoglobinopathy, where the defect is in the hemoglobin itself. That's sickle cell anemia and thalassemia. Or enzymopathy, which is G6PD deficiency and pyruvate kinase deficiency. By the time our Hem-Onc fellows finish their fellowship, this is pretty much imprinted in their mind. You wake them up in the middle of the night, they ought to be able to give you this tabular column, because that's all there is to it. You look at someone with hemolysis, make sure there is hemolysis, and you have to put them into the grid. Get your Coombs back as quickly as you can, and you put them into this grid. Case number 3. We'll move on a little quicker. I wanted to give you the background of what cases are, but there's a lot of polling I want you guys to do with some other slides, so we'll move on. 67-year-old lady presents to her internist with a history of weakness and fatigue of several months' duration. She complains of soreness of the tongue and cracking of the lips at the angle of the mouth. Her daughter, who accompanies her, adds that mom is getting forgetful and unsteady. She has fallen off late, particularly at night during trips to the bathroom. I might throw in that maybe in the shower when she's got soap in her eyes, she's unsteady and falling as well. Past medical history, Hashimoto's thyroiditis, and then we've got a family history of some anemia in the family as well. And this is the smear. Okay? So the question is, what do you see here? Okay, go ahead and poll. Hey, everybody got it. I'm thrilled. Lovely. And this is basically, the story is there, and this is the cell that you want to see, that is a neutrophil that is hypersegmented, obvious, clear. The only other thing that can come close to this is a dysplastic neutrophil, sometimes an MDS, but it's usually not hypersegmented. You just have bizarre shapes and forms of the nucleus. And then I want you to see what macrocyte looks like, a macrocytosis or macrocytic anemia. These are macroovulocytes, and that's very typical of vitamin B12 deficiency. So that's her exam, and as you know, some B12 deficient patients can have a little jaundice. She's got glossitis, she's got cheilitis, she's got the white-based gait, she's got Romberg sign being positive, which is what the daughter was trying to explain, saying she's falling at night because the visual compensation is knocked out when your posterior column is gone. And that's the same thing that happens. It's a wonderful history to ask patients saying, when you're in the shower, when you got soap in your eyes, do you kind of get a little unsteady? You'll be surprised at the number of people who will actually tell you, yes, actually, how did you know that? So that's what the CBC is in this lady. Hemoglobin of 9.8, hematocrit is 28.6, and the MCV is 106.6. 106.4. Platelets are a little bit low because B12 deficiency can give you thrombocytopenia. It can give you some leukopenia. The differential looks okay. These are the numbers. Once you get the B12 back, it's 136. The methyl malonic acid level is a little high, normal being up to 0.4. No hemolysis. Chemistry looks good. So we're home. That's B12 deficiency. But you want to remember the hypersegmented nucleus in the neutrophil and the macroovulocytes, because we're talking the peripheral smear, remember. So it's tempting to make this diagnosis with the history, which is great, and it's lovely to have all these labs back, but what we're trying to push ourselves to say is, can we look through that window into that bloodstream and see what's going on? Differential diagnosis for macrocytic anemia, you all know this, B12, folate. Any reticulocytic anemia may look like macrocytic anemia, liver disease, ethanol use, but the big one for us is MDS. So alcohol and MDS are the two biggies for macrocytic anemia. When you're on Dilantin, when you're on some anti-seizure medication, you may see some macrocytic anemia. Which brings us then to normocytic normochromic anemia, and this is the differential. It could be acute loss, it could be anemia of chronic inflammation, chronic renal failure with a decreased EPO level, that's a biggie out there, and the early stage of iron deficiency. Endocrine diseases may reflect with normocytic anemia, and here are two conditions. And then, of course, bone marrow suppression is classically macrocytic, but you may have normocytic anemia. There's one condition that I've left out, and I tried to add to it yesterday, and I couldn't once I put the ARS in. Can anyone think of what I missed out here? Your classic, as a hematologist, our fellows need to think of it. We will wrap them on the knuckles if they don't think of this differential for normochromic normocytic anemia. Wonderful, multiple myeloma. So multiple myeloma will present as normochromic normocytic anemia, and we see elderly patients who probably have MDS, but they'll be normocytic, and the one thing we'll quickly get is get an SPEP and an IFE and get it off the table. Remember, while it's very useful to have this classification based on the size, in the real world, most patients have a mixed picture. So they won't fall wonderfully. If you have an MCV of 72, that's fantastic, but they won't give you an MCV of 72. They'll actually have an MCV of 86 and have a little iron deficiency, and you still have to supplement with iron. And they'll probably have a little bit of something else that they'll see a mixed picture, so keep that in mind. Case number 4, 44-year-old female with a history of hypertension on lisinopril, works as an accountant at a local chemical plant, presents to a primary care physician with low-grade fever and upper respiratory symptoms. She mentions that she enjoys hiking and kayaking in the spring and summer and wonders about flea bites on her leg. And you actually see some ecchymosis in addition to all this other stuff. And what she has is thrombocytopenia and petechiae. This is her CBC. And you look at the CBC, and there is none of that little itty-bitty dots. Remember, on the first smear, the normal smear we talked about, those little itty-bitty dots? There is not a single, well, there's one. That's a platelet. That's about the only platelet maybe out there in the entire field. So just a case in point about what a peripheral smear and thrombocytopenia would look like. And the etiology for thrombocytopenia is decreased production increased destruction, as you all know, and don't forget sequestration in the spleen in people who have splenomegaly. Pseudothrombocytopenia and gestational thrombocytopenia are two things that you always want to keep at the back of your mind. Gestational thrombocytopenia is basically dilutional thrombocytopenia in the pregnant lady. So this is another snapshot of what we saw earlier, just to show you schistocytes. Beautiful picture of schistocytes. RBC fragmentation, and this particular person had a prosthetic heart valve. Brings us to, what is this? Go ahead and poll and we'll take a look at it in 10 seconds. Nice. That's platelet clumping. That's what a ton of platelets all clumped together would look like. What is this? That's a nucleated red blood cell, and that's a band. And because of this, I threw in sepsis as a differential to see if someone will pick that up. This is not essential thrombocytosis. This is not excess platelets. This is not how you would see it in ET. This is basically platelet clumping. And the first step in evaluating a patient with thrombocytopenia for the Hem/Onc fellow is basically to go quickly look at a smear and make sure there's no clumping, because right off the bat on the algorithm that goes out, and you don't have to worry about that thrombocytopenia because that's pseudothrombocytopenia. Case number 5, 42-year-old male admitted with shortness of breath, chest pain, 4 hours duration, previously in good health, sudden onset of symptoms. He's got a headache, he's got blurred vision, itching in the hot shower, works on a farm in South Carolina, never smoker. He has a ruddy complexion, so he does work on the farm, you can see that. He's got some hepatosplenomegaly and some lower extremity edema. He does have some decreased air entry in the right lung base with some crackles. And basically what we're leading up to is polycythemia vera, or polycythemia. And he's got a high hemoglobin, so he's got a ruddy complexion. He's got hepatosplenomegaly. The aquagenic pruritus, which is the itching in the hot shower, gives you a little bit of a clue there that this is more than just garden variety polycythemia. This is probably polycythemia vera. What he presented with was basically a DVT and a PE. He was having a PE, he had a DVT, and this is what you saw in his hemoglobin. Platelets can be high in P vera, white blood cells, so it's a 3-cell line issue or problem. LFTs are normal except for the LDH. His EPO level as a feedback is low, and the JAK2 mutation is positive. We can have primary polycythemia, which is P vera, secondary polycythemia, which is due to lots of different conditions. P vera is a clonal disorder. It's a bone marrow problem. 95 to 98% are JAK2 positive, and we have 2 different mutations on the JAK2 panel. And the treatment is basically phlebotomies and hydrea. I'm not going to talk a lot about any one particular condition or about the treatment, because I want to give you a snapshot and give you kind of a window into the smear rather than talk about any one condition. Each and every one of these conditions by themselves could be a topic for grand rounds. Secondary erythrocytosis could be just hemoconcentration from dehydration. Pulmonary disease is what I commonly see them with, COPD or obstructive sleep apnea. They could have renal disease. The boards always love hypernephroma and a high erythropoietin level causing secondary erythrocytosis. Rarely will the hematocrit be over 50%. The JAK2 is usually negative. It gives you an idea. Most of these patients, you can just watch them. This is compensatory. We tend not to do a phlebotomy on them. Brings us to question number 5. Okay, go ahead and poll. Nice. You guys are right on top. So that's a teardrop cell. Let's make sure this picks that up. And so that's called a dacryocyte. That's a teardrop cell. That's a teardrop cell. That's a teardrop cell. And so that's very classic in myelofibrosis. You tend to see them with splenomegaly. Some of the most massive splenomegalys are seen in myelofibrosis, hairy cell leukemia, and CML. Extramedullary hematopoiesis is noted. If you do a bone marrow, you tend to get a dry tap. 50% of them may be JAK2 positive. JAK2 again, yes, because they all fall under the same umbrella of myeloproliferative neoplasms. We have 4 diseases that are typical for myeloproliferative disorder. P vera, that's the red cell line. ET, that's the platelet line. CML, that's the white blood cell line. And then MF, where the issue is not with a particular cell, but it's just reticulin fibers that are increased in the bone marrow. These are the 4 atypical MPNs that we come across less frequently. ET, again, a clonal disorder. Platelets are over 600,000. It's a benign condition for the most part. The latest issue of the New England Journal of Medicine talks about telomerase inhibitors, new drugs for ET that we have a phase 2 trial that has got some interesting results with. But remember, this is not a very dangerous disease, even with a 1.2 and a 1.4 million count, so you can wait and watch and see how they do. Secondary thrombocytosis is something that you all will see frequently as hospitalists in the hospital. It's usually due to infection, inflammation, post-splenectomy, or due to iron deficiency anemia. Surgery, trauma, hemolysis, all this will also cause some increase in platelets. Basically, the marrow is churned up, so you're going to see a high platelet with this. Question number 6. Take a crack at it and go ahead and poll. You guys are 3 on 3 for the last 3, I think. CML, leukemioid, yeah. So those are 2 close differentials when you see them in the clinic or in the hospital setting. And the right answer is actually chronic myeloid leukemia. And the reason you would say chronic myeloid leukemia is because you see an entire sequence of maturation of the myeloid lineage here. So you'll see this, that's a band. You see this, that's a neutrophil. You see some myelocytes. You see some promyelocytes. This is a metamyelocyte. You'll see an odd occasional blast or a blast mixed in that circulation. So the entire maturation lineage is available, and you'll see some peripheral neutrophils as well. And that's very classic for chronic myeloid leukemia. In leukemioid reaction, it's a neutrophilic leukocytosis. Most of them are mature neutrophils that are out in the circulation, and that's the difference. But this is just a wonderful snapshot of what CML would look like. Remember, people have been looking under the microscope at the blood for over 2 and 3 centuries. And this very same picture that's there in front of you, not maybe this slide set, and not as a slide set, was what 150 years ago John Bennett in England was looking at, and Virchow in Austria was looking at, and they gave the name leukemia. And that's how the term leukemia was coined, because they said, hey, that's a lot of white cells. These are leukocytes, and these are not red cells. And CML was diagnosed and declared and a label given in the 1850s and 1860s. And so here we are looking at the same kind of, and that's the same peripheral smear that I'm seeing at the Regional Cancer Center today, 150 years later. And so that gives you, in an ever-changing world, there are some things that haven't changed. And like someone once told me when I was in med school and I was completely frustrated thinking I'll never be able to figure all this out. He said, well, our understanding of diseases, the number of diseases exponentially will change. The number of tests that you've got will exponentially change. He says there's one thing that will not, and that is the number of symptoms that a patient can give you has not changed over the last 2,000 years. There was hemorrhoidal discomfort in the Egyptian civilization. There was abdominal pain and maybe even pneumaturia, but they didn't know how to call it pneumaturia back then. And that has existed. So the symptoms are static. And so if you go to the algorithmic basis of making a diagnosis, basically you hang on to the symptom and say, I have to ask the right question. At the tertiary level, I have the answer. And so that's your problem-oriented medical diagnosis. So sometimes when you're overwhelmed with data coming at you from CNN, from the patient downloading stuff from the internet and coming to you, tell them that's okay, that's all right. And I always tell them, give me the journal, and I'll take a look at it, and we'll meet again in a couple of weeks. Let me read about this, and I'll read this very journal, and I'll do a journal club at home for myself, and I'll rediscuss the same thing with the patient when they come back, because most of it is not applicable to that patient's condition. So don't let data overwhelm you in this era. Okay, so that's CML. And translocation 922, 3 phases, chronic, accelerated, and blastic phase. I won't get into a whole lot of details, but you just have to be able to look at CML and look at the smear. It's just so glorious. This is the same patient with CML, but getting to a blast crisis. This is low power, this is high power, and that's a classic blast. Nuclear cytoplasmic asynchrony, a rim of cytoplasm on the side, and that's your typical blast. There are some bands out there. There's an eosinophil. You may see some basophils in CML, but that's a peripheral smear picture of a CML patient going towards a blast crisis. We don't see that as often today as 2 decades ago, thanks to TKIs and the fact that we've got a wrap on this disease for the most part today. Case number 6, 44-year-old male or female with rheumatoid arthritis, had significant vaginal bleeding. This is a true story. A lot of these are, remember, cases we've seen in our clinic or in the hospital. She had some petechiae on her hard palate, 44-year-old, white count was 2.8, platelet was 44, 12.1 hemoglobin, PT was out a little bit, INR was out, she was no history of alcohol, was not taking Coumadin, and she was admitted to the hospital for this. She had a fibrinogen that slowly trended down. The platelet count also trended down over 4 or 5 days. And as the pathologists were looking at the smear, she actually developed a CNS bleed and collapsed and passed on. And what she really had, if someone had looked at the peripheral smear, I was in training at that point, and looked at the peripheral smear carefully, was that she had promyelocytes. And so that's a promyelocyte for you. That's a hypergranular promyelocyte. These are our rods. That's what our rods look like. You're lucky. It's usually seen in AML. And you're lucky if you see 1 or 2 our rods scattered around many blasts. You will not normally see a ton of our rods all in one single cell. And that's fairly classic for a promyelocyte. So this is the dreaded M3 hypergranular promyelocytic leukemia, or APL, acute promyelocytic leukemia, that causes coagulopathy and causes bleeding. And if it's left unrecognized, you have to treat the coagulopathy first and then treat the leukemia. And if it's left unrecognized, this is what happens. You get a bleed, and this patient, we lost this patient. This leukemia has a 90% cure rate, 80-90% cure rate. So the most dreaded variety of acute myeloid leukemia is today one of the most curable malignancies if you know what to look at under the microscope. So that's AML. It could be in the young and de novo, or it could be from antecedent disease in the older patient, which is basically people with MDS. You know the French, American, British classification. We have some WHO classifications on this. Remember, we talked about M3. The M5 is monocytic, causes gingival hyperplasia, and they tend to have CNS involvement. These are things that the ABIM loves to test you guys about. Brings us to case number 7. Retired male, again in a local chemical plant, no B symptoms. He feels tired, but he's playing golf 3 times a week. Pretty handy-dandy handicap there. And his white count is 145,000. No hepatosplenomegaly. He's got some small cervical nodes. But the CBC is unchanged for 2 years. So who's been watching this for 2 years with 145,000? Did they do the right thing? What's up? To marrow or not to marrow? To treat or not to treat? And this is his smear. Take a crack at what you think it is. I've given you lots of clues along the way. All right. CLL. Perfect. So indolent, slow leukemia, white count hasn't changed. Whenever they give us a count, we always ask our fellow, what was the last count? And what was the count a month ago? When was the last normal count? Was it 6 months ago? Was it 6 years ago? Everything has some relevance to me. The chronicity. And so here we gave you all that in the history and what this patient has compared to the earlier slide. Look at this, monotonous. These are all lymphocytes. These are not myeloid lineage. These are lymphocytic lineage cells and monotonous cells, and that's chronic lymphocytic leukemia. This is a higher power. Some of these are atypical. This is what a classic lymphocyte would look like. Small, dense leukocyte, mostly filled with the nuclear material, hardly any cytoplasm. These are slightly atypical lymphocytes, a little larger. The size of the lymphocyte is usually the size of the red blood cell. So an atypical lymphocyte can be a little larger, and that ends up being a little larger, and you have a little more cytoplasm, and that's an atypical lymphocyte. Yes?
How do you differentiate this from smudge cell?
From smudge cells. I wish I had a picture. A smudge cell is basically a broken down cell. So it is just a smattering of material out of the cell that is picked up on a stain. It almost looks like artifact. So we call them smudge cells, but they're not really an entire cell with a membrane. They're just a lot of material on the slide, which is because of a high white count. As they make the smear, it's an artifact, it gets broken up. Okay? So that was this patient's CBC, and the simple thing is you see the white count and you see the diff, and there's an inversion of the ratio and it tells you the answer. At CLL, absolute lymphocytosis should be over 5,000 to make the diagnosis. We have various classifications. This is in North America, the RAI classification. The Binet classification is more popular in Europe, and we have the various classifications here. We do not need a bone marrow biopsy to make the diagnosis. We can do a flow cytometry of the peripheral blood, and that's enough to make the diagnosis of CLL today. Elderly CLL patients, we still would prefer to do a bone marrow biopsy and make sure there's no other underlying condition. Watchful waiting does have a role along with chemotherapy, and we risk stratify CLL. Like I said, it's an entire grand rounds presentation in itself, but we risk stratify to decide who gets treated, who doesn't get treated. This is not a polling question. I think we're done with the polling questions, but this is just to give you, we're coming towards the tail end of the presentation to give you a snapshot of various slides. Any thoughts what this is? Nice, I think I heard that answer. Look at these little projections. Hairy cell. So it's a lymphoid lineage cell. These are lymphocytes, but atypical lymphocytes, and they have projections. Even on the low power, you can see these projections, and that's hairy cell leukemia. It's an indolent neoplasm. Remember, I said pretty large spleen. Bone marrow biopsy could be a dry tap. Under the microscope on the bone marrow biopsy aspirate and specimen, you may see a fried egg appearance. And treatment is pretty, prognosis is, it's an indolent, slow leukemia. So you've got treatments available, and we see an 85% survival at the 10-year mark. Case number 8, 59-year-old veteran working a summer job at the local race course. That could be the Bristol Highway. He's got heat exhaustion, he's dehydrated, he's got some mild hemorrhoidal bleeding, and he's voiding well. Those are his labs. Take a good look at those labs. So he's given IV fluids, he's dehydrated, and he's sent home in 2 days in our push in the new era to get people out. And he's readmitted to the hospital in 8 weeks with severe hip pain and left rib pain. What happened? Because the answer was somewhere in those labs out there. He's got a creatinine of 1.9, he's got a calcium of 11.4, multiple myeloma. Look at the total protein and look at that albumin, and a big separation between the albumin and the total protein. He's got some normochromic normocytic anemia. MCV is normal, like we talked earlier. And that's what is plasma cells, and this is actually a bone marrow aspirate, so this is not from the peripheral smear. These are absolutely gorgeous looking cells when you look at them under the microscope. The nucleus will be eccentric, the chromatin will be wide open, and they actually have the spokes of the wheel kind of appearance on each of these nuclei. And so that's plasma cells. And when this spills out, this normally stays in the marrow. When this spills out into the peripheral circulation, and it can, rarely, it's a terrible disease. It's plasma cell leukemia, very poor prognosis. So that's what this man had, is multiple myeloma, so lytic bone lesions, classically seen in the skull. It could be seen in the hip. There's a sclerotic foci there. What are these? Pathological fractures with callus formation. These are real life stories. We have pictures. These are all cut and pasted from some of our patients. So that's plasma cell dyscrasia, multiple myeloma, MGUS, plasmacytoma, and light chain disease. They're all part of the umbrella of plasma cell dyscrasia. It's a clonal proliferation. It is a B-cell neoplasm. The plasma cell is a B-cell neoplasm. And you all know about CRAB, the mnemonic for target organ damage, hypercalcemia, renal insufficiency, anemia, and bone involvement. If you see this, you move over from smoldering myeloma into multiple myeloma. And you also have the condition MGUS, which is monoclonal gammopathy of undetermined significance. You have a paraproteinemia, but the spike is lower. When you talk of an M spike, remember the M does not signify IgM. It just signifies monoclonal spike. So when someone says, what's the M spike? It could be an IgG, it could be an IgA, just keep that in mind. And so in MGUS, they do have an M spike, just like myeloma has an M spike, but the height of that M spike is low. And this is what the ABIM will test you. It's a 1% transformation per year to multiple myeloma. We, of course, risk stratify MGUS, and we've got a Mayo criteria to hair split it further. Some MGUSs which will never probably go into myeloma, and some MGUSs have a 50% risk of turning into myeloma within over 20 years. So MGUS is still a good disease. It is not yet pre-cancer. It's definitely not cancer. I do not even like to use the word pre-cancer with MGUS, because as an internist, you'll see a lot of patients with MGUS, and they just need to be watched and periodically followed. So the last set of slides, which are just pictures, just to have fun and take a look at it, these are acanthocytes, reflection of the systemic illness in the peripheral blood. These are spur cells. These projections are spiny, long, and they indicate liver disease usually. Rarely it could be A-beta lipoproteinemia, but it's usually liver disease. So that's an acanthocyte or a spur cell, basically very spiny and very long, as compared to this, which is called a Burr cell, and that's an echinocyte, and this is seen quite frequently in uremia and renal failure. So you take a look at a lot of your renal failure patients and go take a look at the peripheral smear, you'll see a lot of Burr cells. Hereditary elliptocytosis, and as the name suggests, fairly classic and obvious. Stomatocytosis, cells where the central pallor has the suggestion of a fish mouth open, and that's stomatocytosis. Basophilic stippling, stuff that we've read about and seen in Robbins before, and that's fine stippling, coarse stippling, and you see it in lead poisoning, you may see it in thalassemia, you may see it in anemia of chronic disease. Howell Jolly bodies. That's a Howell Jolly body. That's a Howell Jolly body. That's the Howell Jolly body. This is what you see in the peripheral smear. And what happens is, as you can see, these are basophilic remnants of the nucleus. The red blood cell is anucleate. It loses its nucleus. Every once in a while, there are portions of the nuclear membrane or the nuclear material that still stays in the red blood cell. And when it stays in the red blood cell, those are Howell Jolly bodies, but normally we don't see it, because the spleen cleans it out. It takes a look. Remember those bite cells? The spleen doesn't like anything that's abnormal. So you see this red cell floating by with a nuclear material close to the cell membrane, it just chews up the entire red cell. So in your circulation and my circulation, we don't see Howell Jolly bodies. So when would you see it? When you knock the spleen out. And that's why when you see Howell Jolly bodies, they're usually a sign of asplenia, either functional or anatomic asplenia. And interestingly, naphthalene mothball ingestion leads to some Howell Jolly bodies as well. Do not keep this picture in mind. I showed this just because the Howell Jolly body is so well made out. This is a magnified view. This is not what you would see in a peripheral smear. And this is really a red blood cell with a nucleus. And that's not normal. This is an erythroid precursor, but just a handy picture to show the Howell Jolly bodies. This is probably what you will see in a circulation. Yes, question? So the question is, how would you differentiate it from Haynes bodies? For the Haynes body, remember the Haynes body will never show up on a peripheral circulation. You need a supravital stain. So you do a special stain to pick up the Haynes body. To find the denatured hemoglobin, you need a Haynes. So the Haynes body will not be seen on a regular peripheral smear. Whereas a Howell Jolly body can be seen on a regular peripheral smear. And these are called RBC inclusions. So very good. We're getting to the tail end. And I'll give you a little algorithm about when you see a peripheral smear, how do you document it? What would you put down? This is ringed sideroblasts, RARS, refractory anemia with ringed sideroblasts. If you remember, MDS, the FAB classification. We now have a WHO classification. That's just iron granules being deposited in the red blood cell. Okay? This is the malarial schizont. That's malarial parasite in a red blood cell. Somebody with fever, you take a look at the peripheral smear, you need a thick smear at the thick end of the smear, and you'll actually see the malarial parasite in the red blood cell. There are two organisms that can get into the red blood cell. One is the malarial parasite and the other one is Babesia. I tried to find pictures, I couldn't. There were a couple that I found, they weren't very good pictures of Babesia in the red blood cell. This is toxic granulation, as the name suggests. Somebody is septic in the ICU or in the wards and very sick, and that's what you would expect to see. This will give my hemonc fellow, make him shudder a little because you don't know which is toxic granulation and which is hypergranular promyelocyte, except there's a lot of cytoplasm and the nucleus is not large enough to be a promyelocyte. But you can get the APL variety will have a lot of granulation. So even the pathologist will sweat over this when he calls this a toxic granulation. But this is pretty classic. You have the joy of knowing the patient and knowing that they came in bacteremic and that's what your blood culture showed and this is what's going on with them and it's resistant and we switched antibiotics and you see this in the CBC, then you worry less about APL and you say, no, this is toxic granulation. This is a Dolly body and that's why I picked up this picture. This is a giant platelet. Normal platelets are small. This is a giant platelet. This is a neutrophil and that's the Dolly body in the neutrophil. It is seen in this rare inherited abnormality called May-Heglin anomaly. You tend to see the Dolly body in the neutrophil. You'll tend to see giant platelets with them. That's infectious mono. It's an atypical lymphocyte. Of all the leukocytes, the lymphocyte has the largest variation in morphology. It could be large, it could be small, it could be kind of all sorts of weird things. With viral infections, you see atypical lymphocytes, they are reactive lymphocytes. But there's one atypical lymphocyte that's characteristically seen in mono, and that's your infectious mono. Really large, and they have this appearance where the red blood cell will indent this, the cytoplasmic membrane. It's almost like a skirt. It's called the skirting or the fronting of the skirt with a red blood cell on the lymphocyte. And so that's infectious mono. This is a blast. So the two things that my fellow has to know when he goes in the middle of the night to see the smear, he needs to know how to recognize a schistocyte and he needs to know how to recognize a blast. And so that's a blast. Large cell, much larger than the red blood cell, a lot of nucleus, thin rim of cytoplasm, and that's not enough. Don't go by size. We'll see a lot of MDS patients with a lot of large myeloid cells, but that cytoplasm is agranular. There's no granularity to that cytoplasm. As you get more mature to promyelocytes, metamyelocytes, and myelocytes, the cytoplasm develops granularity. So when I see a very hyaline, smooth cytoplasm, that worries me. That's a very early immature cell and a blast. That's more of a blast from a patient with AML. These are all from the ASH image bank. You can go to the American Society of Hematology, log in. It's open to the public. It's certainly open to students and residents, and you can look at a lot of these pictures. That's a peripheral smear on someone with acute lymphoblastic leukemia. The blasts are actually smaller. They may be intermediate sized in ALL. So that brings us to the end of the talk, and we discuss the evaluation of the peripheral smear. And just like you look at an echo, as an internist, I used to read my own echoes, and you had a way of following an echo. You would look at all the dimensions, the left atrial size, the left ventricular size. A lot of it, my tech would measure it out and give it to me. And I knew what the interventricular thickness was, if there was left ventricular hypertrophy or not. Then you would go to the valves, and you'll see if the aortic valve, take a look at it and see if you see the Mercedes-Benz sign, is it tricuspid, is it bicuspid? Look at your mitral valve changes, is a systolic anterior motion. Then you'd get to the meat of the matter. You really want to know the EF, but you hold yourself back, and then you wait for the parasternal lung, the short axis view, the 4-chamber view, and say, that's my EF. I'm going to eyeball it and say 55%. Same thing with the peripheral smear. You're in a rush to see, is there a blast? Is there a schistocyte? Oh my God, do I need to call someone else? Do I need a bone marrow biopsy? And my philosophy is to follow an orderly sequence. So red, white, and blue, that's the easy way to look at it. And the W there, or the white there, does not stand for the white blood cell. Look at the red stuff, that's the red blood cells. The white is the background. Look at the platelets, because you have to look in the background for those little itty-bitty dots, and those are the platelets. And you don't really look at platelet morphology. They're too small. You can look at megakaryocyte morphology, but not at platelet morphology. So you're looking at the platelets to see, is there clumping? Is there an adequate number of platelets? Are there giant platelets? We looked at all of them today. So you start with the red, white, and blue and look at the red blood cell. What's the size? Anisocytosis or not? Shape? Poikilocytosis or not? Look at the morphology. Am I seeing schistocytes? Am I seeing sickle cells? Am I seeing abnormal morphology of the red blood cells? Then rarely am I seeing RBC inclusions. Am I seeing Howell-Jolly bodies? Am I seeing a malarial Schizont, etc.? Done. Red cells out of the way. White, red, white, and blue. The platelets, real easy. Is there clumping? No. Is there enough platelets or not? No. Am I seeing larger platelets? And believe me, seeing those larger platelets warms our heart. So when you guys call us for a consultation and call us for thrombocytopenia, and we're worried about HIT and we're worried about other things, and I go look at it and I see some larger platelets and giant platelets, I know that marrow is working. It's spitting out early platelets into the circulation. And I know this could be ITP. And so ITP, you'll see some larger platelets and giant platelets. So this is not all theory. This is exactly what you would see at the bedside and in the lab to apply to your patients. Then you come to the blue, and which is all your leukocytes. And you go look at the differential, look at individual lineages, look at your neutrophils separately, look at your lymphocytes separately, look for the immature cells and blasts. Then you look for the inclusions, you look for the toxic granulation. Then you say, okay, and then you record it in the same way. Now, you guys as internists are not expected to do all this. My fellows ought to be recording all this in exactly in a certain fashion, just like you would record an EKG or an echocardiogram. So we talked about the CBC and its components. We talked about the peripheral smear, normal. We looked at a lot of abnormal smears. We looked at iron deficiency, hemolytic anemia, and megaloblastic anemia. We went over a little bit of TTP and ITP. We looked at the myeloproliferative neoplasms. We looked at AML, CML, CLL, and then we looked at some plasma cells and multiple myeloma. And there's just an esoteric collection of things that can reflect systemic illness. The peripheral smear does not hold all the answers, but the peripheral smear is like a keyhole. It gives you a sneak peek into what's going on into the circulation. So with that, I'll stop with an ode to the blood counts. It's an alteration of Thomas Gray's story and about many cells that are constantly made in the bone marrow and are never seen by any of us under the microscope, and they very faithfully do their job and are lost. So this was one of my father's favorite quotations, so I just like to put it out there. Full many a flower is born to blush unseen and waste its fragrance in the desert air. Full many a gem of the purest ray serene, the dark unfathomed ocean caves bare. So this could be a little niche in the bone marrow that Dr. Mocha might be looking at maybe tomorrow or day after. So, okay, questions? Yes?
How specific is, when you see like toxic granulation, how specific is this to like bacteremia or?
Wonderful question. So he's asking me about how specific is seeing toxic granulation. And when we look at the peripheral smear, things are not very specific. So one of the things is we are in an era where we look at the sensitivities and the specificities, and we want accuracy, we want reproducibility. And the funny thing about hematology and oncology, they're two specialties that are wedded together, but they're completely different in their philosophies and approach. So I'll answer your question, but I have to give you a philosophical perspective to this. In oncology, everything is data-driven. We've got prospective randomized double-blind placebo-controlled trials to tell us what's going on and to see what the p-value is and if the data is there. Hematology harks back to 150 years ago, where you look at things and maybe not. So when you look at toxic granulation, or what looks like toxic granulation, when you look at these peripheral smears, I've shown you classic pictures of what is classically there. When you actually go and look at the microscope and look at these, there'll be plenty of cells that neither you nor your attending will be able to call. And don't hesitate to say, I don't know what that is. But to a large extent, the diagnosis is made by the company that a cell keeps. So you need to see more of that. If you think there was one schistocyte, go look for more. See if it's keeping company with other schistocytes. And if you don't see a whole lot of other schistocytes at all, I'm not worried about one that looks like a very classic helmet cell. I'm still not worried. So to answer your question about, is that specific? No, it's not. You tend to see it. You can have a lot of patients with sepsis and not have toxic granulation. And you can have a few patients with few patients in whom your smear shows toxic granulation. You know that the marrow is stressed. You know that there is an infective process going on. There may or may not be spiking temperatures. It may be based on the fact that someone's getting Lortab Q6Rs, which has got Tylenol in it, or the fact that you've got them on appropriate antibiotics. So in the hematology world, what I actually push a lot of our fellows is to say, learn to accept the mysticism and not have all the answers. So we get these consults from you guys on the inpatient service from the ICU saying, tell me, is this really it? And I really don't know. And that's the honest answer. We go through the differential, we look at it, we look for all the bad players. And then I tell them, learn to accept and say, I don't have the exact answer, but this patient we will watch, which is why we come every 48 hours or 72 hours and write a note and say, we'll follow, monitor, continue looking at the trend. And the absolute delightful thing is, whatever you all do, which most of the time happens to be the right thing, when I give them a 4-week, 6-week follow-up back in the office, those counts will normalize. It gets better. So sensitivity and specificity for something as ancient as this, which is now 3 centuries old, doesn't apply too well. There are a few things you can hang your hat on. So if I look at an immature cell and I see that blast, yes, I'm going to move on it. A few things like schistocytes, I'll move on it. A few things like teardrop cells, I've marrowed them and they may not have myelofibrosis. So it's not very specific. It really goes back to what you all were talking earlier in the other session, the 3-legged stool, where you have the patient and the clinical parameters, you have some biochemical parameters, and in this era, radiographic parameters, you put it together. So this is a wonderful adjunct. It's not, we're in this era where we want to go on Google. My son wants to have that answer even before I turn around and finish the question. He's got the answer for me because he knows how to hit on these things. In the human body and really in real life and in the clinics, you cannot have all the answers. And you learn to accept some of it, which is why you create the differential and you give weightages and it moves back and forth. And that's what I want to open your eyes to out here, is to say, this is a little window into the human body, a little window into hematology and all those disorders that may be there, you may worry about, but may not pan out. Long answer to a fairly straight question. There isn't a sensitivity or specificity for this. You guys have been a patient audience. Is there any other questions I can answer, or I'm happy to answer them after the session? Wonderful. Thank you so much.